Great. Thank you, Ruth, and thank you for everyone on the panel. I'd just like to wrap up and identify there are a number of themes that emerged from the presentations. One was the need for some dollars to help build capacity so that safety net providers can actually, even if they do receive incentives, they can actually ramp up and have the infrastructure to be able to receive the incentives. The need for HIT and workforce capacity and skills within the safety net community. The need for training and how to use data to improve quality of care. That's a huge need. The need to integrate both behavioral and oral health services because that's so intertwined with comprehensive health care. The need for consumer education and outreach about the benefits of HIT and ongoing monitoring of our movement and our adoption rates to ensure that the safety net providers are adopting at least at the same rate that other providers are. And then the last thing I'd just like to identify that although we tried to hit all and include all safety net providers, we have to admit we did not include all safety net providers in all populations. We've left out prison health, certainly left out homeless we touched on a little bit, migrant health. So there are other populations that this was not all inclusive. So, and in the interest of time, we were not able to do that. So with that ends our presentation. And then I think we'd like to open up for questions and answers. Okay, we have a couple of questions from outside. And first one is, most are aware of the absence of the support of ERA funding in the local government healthcare IT incentives. How can local governments and others that have been included in the mainstream to create a lobbying consortium to speak about our needs? Have not been included. And from Steve Emanuel. Sorry.
We only have about a minute for an answer.
Okay, so does anybody want to address that one?
I'm not sure we understand.
It's how can local governments and others that have not been included in the mainstream to create lobbying efforts to speak out about our needs?
Well, I think the first thing, if the question is, if I understand it correctly, this is Nicole Lamoureux from the National Association of Free Clinics. I'm Nicole from the National Association of Free Clinics. If I understand it correctly, I think what they're asking is how the local governments can get involved. I think some of the best ways that we always encourage, and I'm sure you all do this too, if your local governments have not visited any of the safety net providers, to go there first and to take a tour and see what they actually do every single day. Why we suggest that is because without knowing what you're talking about, it's very hard to talk about. And then I think that really we've encouraged town hall meetings at the local level. We've encouraged letter writing campaigns. I think you can outreach to any of us on a national level. We can help you a little bit more, but I think the word of mouth, using your papers and talking to people and establishing meetings will help elevate what we're talking about, the disparities that are there now.
Great, thank you. The next question is from Rebecca Birch. And the question is, I know that several panelists raised concerns about some vital safety net providers not being considered or eligible for Medicaid and Medicare incentives. What is currently being done to address this, or what do you feel should be done?
It's a little preliminary, but I think that the obvious thing for us is sort of looking at. Oh, sorry, what?
Just say who you are.
Alexa Eggleston from the National Council is looking at a legislative fix. Whether it's coming back around to, look at language that needs to be tweaked within our, whether it's a heavy lift or not. I think that's something that we're sort of having very preliminary conversations about, is sort of getting additional people actually written into those incentives. And again, I think the other thing is in part waiting, but I think we're really looking for very clear guidance about the incentives that do go to psychiatrists, which sometimes our house and our members, sort of what does that really mean if it's going to the provider and not the organization? And what is that, sort of how does that pan out? And so I think we're hoping that through regulatory guidance as well, there may be a little more flexibility around our members at least qualifying. So.
This is Ruth Perot from Shire and the Collaborative. I think this, in light of the fact that our representatives are home and in their districts, it's a great opportunity to inform and educate them regarding these issues. The fact that there are important exclusions that could be remedied through health reform legislation is an opportunity, and this is one that I think we should all take advantage of.
This is Alexa again. The other thing that I'll say is that, Congressman Kennedy did a few months ago sent a letter to, Secretary Sebelius and I think the Blumenthal about sort of the need to be thoughtful about behavioral health providers in terms of implementation around the HIT stuff. So I think there's always sort of that pressure point as well. I don't know if they have plans to do anything additionally, but I think that's one office in particular who has been very vocal about behavioral health issues, who we sort of consider as a champion, and I think sort of continue to think about ways to have members of Congress be helpful as well.
All right, thank you. Another question is from Ed Pontius, and patient control of health information release. This is regarding patient control of health information release. Do panelists endorse patient rights to granular health information release? Is there any prospect of supporting patients in granular control among populations discussed today? So I think what he's talking about is at the level of an electronic health record, are we discussing with patients the ability to only release certain parts of the electronic health record, and what are our views on that? I mean, from my point of view, from health center world and being a behavioral health provider as well, I think that is an important component of EHRs and should be encouraged, and it's a piece of the educational component that we have to relay to patients as well. It's, I think, a hurdle for electronic health records to be able to do that, depending on how they are structured. But I think that granular control is important for patients and patients' rights. And so now we'd like to open it up to any members of the board who might have any questions for the panelists.
Well, Mike, thanks for bringing such a great panel here. I really want to thank you all, because I represent the American Hospital Association, and what your representatives do is very, very important for impacting our hospitals across the United States, especially the emergency departments. I know in our community and many communities, our hospitals do try to work very collaboratively with all of your organizations. I know in our particular organizations, we actually donate hospital time and physician time as well to the free clinics and things like that, and we try to be as very, very supportive as we can. I have somewhat of a checkered past, and I have also run state hospitals and been a state mental health director and state substance abuse director, and I have some really strong convictions about this being probably our worst failed social policy that we have. And especially having you here representing counties and cities, we know the impact on jails and prisons, and just the way we're disproportionately impacting resources. We know the impact on our emergency departments, which is overwhelming. The fact that many times you have law enforcement sitting there for hours while we're triaging a patient, trying to take care of really sick patients, but there's somebody there that also is very, very sick. At the local level, one of the things that's really impacted us is our inability to share data because of many of the confusing issues surrounding HIPAA and sharing patient information. And as you know, for many, especially the mental health consumers, the complex medications that they're on and the complex physical disorders as well as the chronic mental illness make it very, very difficult for us to see a patient when they just show up and really try to do the right thing. And not having that information is extremely difficult for our physicians. And I guess maybe this is more directed at you, Alexa, especially being an attorney, but is there any policy guidance that could be given through your organization, or some way that there could be clarification through HIPAA or OCR or somebody that could say, this is very, very important. We as well have done consumer, and especially me being an director, we have a lot of access to mental health consumers. I convene a lot of mental health and substance abuse consumer groups, and we've experienced the same thing where the high degree of those consumers want to have electronic health exchange. They know that when they show up and they're sick, they really need the information there, and yet we're not able to really provide that information for them. So the consumers want it, but we seem to have mechanisms that prevent us from kind of sharing the data at a level that really is what we all want, is quality patient care.
This is Alexa. I do know that there is generic guidance on HIPAA. What has been done recently around sort of HIPAA, EHR, I would add 42 CFR that sort of governs, specifically addiction treatment centers and sort of their records, as well as sort of the range of state privacy laws that exist. I don't think that there has been any sort of good analysis of that. I know that the privacy issue, I think in particular in sort of the mental health and addiction field, is a dicey one, maybe I would use that word. I think because you still have a lot of people that don't want their primary care provider to know about a history of mental illness or a history of addiction problems because they still fear the stigma and the backlash and the employer and just the things that sort of I think people often get concerned about, whether valid or not, I think still exist. And so I think it's something that I know the Substance Abuse and Mental Health Services Administration is sort of having internal conversations about what can they sort of be doing as the federal entity within HHS that is really tasked for representing these issues. And so we haven't done anything recently, but I think it's definitely something we're trying to get someone to fund to do. And so I think, in terms of the HIPAA stuff, there's an organization called the Legal Action Center out of New York that's done, a lot of just general education about what is HIPAA, what isn't it, what does it do. But I don't know if they've done anything looking specifically at EHRs, but could certainly check and get back to you.